Hi, everyone. We're just getting started. I know folks were online waiting to join. This is the beauty of technology here. I just want to welcome folks to this workshop. This is Centering Equity in Payment and Delivery Reform. Ignatius Bao is going to be moderating this workshop. Ignatius is an independent consultant who has previously worked as at a statewide private health foundation, policy director, and program manager for health equity and immigration and civil rights. He's an attorney. He is an expert on healthcare and delivery system transformation policy, and we're just really thrilled to have him with us today. With that, I'm going to turn it over to Ignatius to facilitate today's workshop. Thank you.
Great, thank you, Carrie, and welcome everybody to this workshop. Really happy to have this conversation to follow the plenary session, where we looked at a lot of different data that I think we're reminded that the disparities do exist, and the latest report that CPIN has issued is going to provide everybody with even more data. And so we encourage all of you to check that out. In this conversation, we're really going to talk not just about access. Certainly in this era of COVID, we think a lot about access to testing, to vaccines, but the other part of healthcare that we don't spend a whole lot of time talking about is how healthcare is actually delivered and how healthcare is paid for. And if we go back to 2010 and the Affordable Care Act, a lot of the reforms that we're familiar with, the setting up of the marketplaces like Covered California, the expansions of Medicaid, were so important to addressing equity in communities of color. But there were many, many other parts of the Affordable Care Act that was about transforming the way that hospitals took care of their patients, transforming the way that community health centers and individual physicians practiced, how to use and leverage electronic health records, and then more importantly, that we'll have some conversation about this morning, is about how healthcare actually gets paid, moving away from paying fees for services, so for office visits, for individual procedures, to really trying to move towards paying for health. And I think COVID has really helped us understand not only the existence of disparities, but the importance of these kinds of delivery and payment reforms. Our speakers are going to talk about the challenges that COVID presented and how, if we had different kinds of payment and delivery systems in place, we might have been better prepared to continue to provide the healthcare that Californians needed through this time. The other thing that COVID has really highlighted, that many of you as consumers, as individual patients have experienced and have helped your family members with, is telehealth. And so the ability of the healthcare system to transform from in-person visits to phone and video visits really has demonstrated that transformation can happen, and it can happen quickly. And so my challenge in this conversation will be, how can we disrupt healthcare in the way that COVID and telehealth have, in a positive way, to really get us to moving towards equity in a different kind of way. So I'm really pleased to be able to moderate this panel. I'm going to introduce the speakers one at a time. They're going to make brief introductory remarks, and then hopefully we'll have a lot of time at the end for some questions and answers with all of you. So our first speaker, I really am honored to welcome Will Lightbourn, who's the director of the California Department of Healthcare Services. Will has had long public service in my hometown of San Francisco, and we're really pleased with his leadership that he's already demonstrated and his ability to talk about equity as a core function of what the department is trying to accomplish for Californians. So, Will?
Ignatius, thank you so much for the introduction, and good morning, everyone. Eliminating inequities is harder than acknowledging them. This is a conversation that's been centuries in the making. I mean, I think we are ultimately talking about the effects of racism, sort of the original sin of the Anglophone world. And so as we approach this, we do so, in our roles and with humility. At the Department of Healthcare Services, we're responsible for the Medi-Cal program. And as I think of it, we have three functions, three levers. We design the Medicaid delivery system, we purchase the services, and we evaluate the delivery. The priority of the past couple of administrations was to expand the program, and it now serves 13.5 million people. That's a huge success. No other state expanded coverage for the poor as completely as California. Still, we do have inequities. The slide that is up sort of references what I think of as the steps in centering a system of equity. First is we have to recognize that policies, while they may apply to everybody equally, are not inherently equitable. An example from just this past week was a hearing on the asset limit test for seniors and people with disabilities to be eligible for Medi-Cal. The maximum asset that they may have is $2,000 in a bank account or a retirement account. However, there's an exemption for owning a home if it's owner-occupied. But if we think about who owns homes among the elderly, it is primarily whites who own homes. So immediately we start with a recognition that a policy that applies equally is not equitable. And what I think this really calls us to do in a sort of a systematic way is be sure that we are thinking about policies through the lens and the eyes of the people who are affected by them. The second thing that is core to how we approach this is the definition of health. The healthcare system largely has been something that is clinical. It is something that is treated by medical interventions, despite the fact that bodies of research make clear that medical interventions really don't add much more than 20% towards wellness, a person's wellness. The remainder are social conditions like inadequate, crowded housing, conditions of low income, of inaccessibility to jobs and capital, things like exposure to violence, things like exposure to violent policing, mass incarceration, the whole panoply of sort of racialized capitalism. And these are things that affect poor people, but particularly Black, Latinx, and Native American poor people more than other racial groups. And so as we move forward, we have to be willing to define health as being more than a clinical intervention. It has to be a whole person approach that includes addressing those social determinants of health. The system design, as Ignatius sort of said in his introduction, we've moved away from traditional fee-for-service over the years. Fee-for-service was sort of also known as fend for yourself. Find a provider who will take our relatively low Medi-Cal payment rates and self-navigate through systems that may not be readily available. So over the past 15 years, there's been a major move to managed care. The expectation in moving to managed care, of course, was both that the managed care plan would do the navigating for the consumer, but also that by being able to sort of spread the risk over a whole population, that they would be able to provide care and services at the rates that the Medicaid system was able to pay. We now have 85% of all of our 13.5 million beneficiaries in managed care. So what that, of course, immediately points us to is that how we manage managed care is going to have an enormous impact on what the system provides. And that takes us to our contracting with our managed care plans, what we are paying for. The priority in the past has been availability. We refer to it as network adequacy. Are there, in fact, providers and appointments available for the consumers? We have an external quality review organization that does 90,000 outbound calls every quarter to determine how quickly appointments can be obtained from providers, what the wait time is on call lines, whether there is adequate translation available. This is all good and well, but it presumes that the availability of service equates to the quality of service or equates to care itself. And while the availability is essential and is important, we need to be going layers down into what the experience of the consumer is and whether their holistic whole person needs are being met. Then we have the question of how we pay for services. And with almost no exception, we pay by a fixed cost times a volume. So we will pay clinics a PPS rate times the number of days that clients access the clinic. We will pay hospitals rates for procedures times the number of those procedures performed, with a few exceptions for catastrophic sorts of events. We will pay skilled nursing facilities a daily rate times the number of residents in the facility, and we'll pay managed care plans a fixed rate times the number of beneficiaries who have signed up with the plan. There's been interest and movement across the country to sort of start saying, how do we have value-based payments? How do we pay for outcomes? How do we pay for improvements in health, in people being healthy? And that is certainly something we're committed to, but we also have to exercise some caution here. We don't want to be in a position where we are perversely incentivizing plans to cherry pick the well. I mean, it's relatively easier to show good outcomes if you start with somebody who's healthy in the first place. And so to adjust for that, we sort of overlay what they call risk stratification. So we want people to start with those most at risk. And even there, we then have to really sort of examine what are in those algorithms. Some risk stratification algorithms are sort of based on cost and the consumer's prior experience as a cost factor. Well, Black beneficiaries consume less medical care than other groups. Therefore, they will not appear as being as high risk as other groups. And so those are the sorts of things that as we do system redesign, we have to be very conscious that the laws of unintended consequences are still in full force out there. And then we have workforce questions that we have to address. Clearly, the people who are engaged at that sort of sacred point of engagement with beneficiaries, in many cases, don't look like the beneficiaries, don't have life experience of the beneficiaries. And with the best of intentions, their biases and their histories come into play and affect both sides of the interaction there. There was a study not long ago that sort of compared a random group of physicians in the US with a similar group in France and had them review case notes for two otherwise identical patients, one black, one white, and sort of report whether they had optimism about outcomes. The French doctors did not have any noticeable difference. The American doctors, unfortunately, were much more optimistic for the health outcomes for the white patient. And as that was unbundled, it was because they had assumed a greater level of personal responsibility for self-care. Again, without in any way impugning the motives of people who go into the helping professions, we simply have to acknowledge that we bring our histories with us. And in the short run, even while we try to sort of expand the availability of peer providers in the behavioral health space or community health workers in the community space, we must also be sure that we are working very closely and holding accountable our provider systems to embed work around cultural awareness and cultural humility at that point of the sort of the sacred encounter. Where does this take us? Where do we go from here? The administration, as you know, has sort of launched the CalAIM initiative, which is a fundamental redesign of our Medi-Cal system to move to a whole person, person-centered population health approach, and to incentivize our provider systems to employ the social determinants of health to reach a whole person approach to care. This sort of will launch next year, January, and our expectation is this will sort of start us on a path towards using the tools that can be most meaningful. The other thing, which is of course underway, is we are going to re-procure for the very first time all of our commercial managed care plans in California. And as we do that, we're going to be looking at them to be engines of delivering the goals of the CalAIM reform. We're going to look to them to be employing social determinants of health, enhanced care management, build on the health home and whole person care models. And very specifically, we're going to look to them to develop and address strategies for closing racial disparities and racial inequities in health outcomes. It's going to be a heavy lift. We expect the new contracts to be in place by January of 2024, but with the support of all of the community groups that are in the CPEN network, we're confident we'll get there. So Ignatius, let me wrap it up there.
Great, thanks so much, and we'll come back and have some additional conversations about CalAIM and the re-procurement, which are the two opportunities coming up. But next, let me turn and introduce Dr. Peter Long, who is the Senior Vice President and Chief Healthcare Transformation and Affordability Officer at Blue Shield of California. And Peter was a colleague of mine at the California Endowment, and then led the Blue Shield of California Foundation, and is going to talk about what Blue Shield has been doing in this area beyond just Medicaid, but also in the commercial space as well. Peter?
Great. Thanks very much, Ignatius, and welcome to everyone. It's always a pleasure to follow Director Lightbourn, and you, Ignatius. You have such a thoughtful framing of these issues, and to lay it out so beautifully, both understanding its complexity, but also bring it to a human level, that it's ultimately about humanity. And I particularly liked where you ended, Director Lightbourn, with the Cal AIM and the reprocurement, because my first comment is, while health plans in our fragmented healthcare system form mini ecosystems, and I'll talk more about that and how we at Blue Shield are trying to shape our ecosystem to drive toward health equity and to better health outcomes. Ultimately, we need a strong lead, and we need a strong lead from the state and federal governments to give us the guideposts, to give us the direction, to give us the policy framework that encourages all of us to move forward together on health equity. I would just also second, while we've been talking about this for millennial or centuries, I've done some work on healthcare and talking about the disparities and understanding them. I do feel like this is a moment of action, and I do feel like we're moving from a paradigm of do no harm, which is the Hippocratic Oath, to do some good, do something in the world that looks different. It's enough time that we have documented disparities and documented these things. It is actually time for all of us to take collective action to drive actual change that people experience in their lives. And I think that's where we're starting at Blue Shield, with appreciation for the state of California and the federal administration. We believe we'll set a very strong framework. And then it's time then to take action and to do some work to get there. The second framing conversation, I would say, and this builds on your point as well, Director Lightbourn, is this has to be about commitment. We have so much compliance in healthcare. And to me, compliance, whether it's our 1,300 quality measures or our slow pace into pay for value, or our inability or unwillingness to share data with one another, that reflects low trust in the system. And when we have compliance, we don't have the freedom to think bigger. We don't have the freedom to be aspirational. And frankly, we don't have the freedom to fail and to learn and to try to do something different. So what I really appreciate and what Blue Shield is committed to do is being a committed partner and actually publicly committing to this work, committing to improving health equity, and making this part of how we do business, how we engage, not just in Medi-Cal, but for all of our 4.5 million members here in California, and frankly, for all Californians. So we have three pillars to our work at Blue Shield of California. And the first starts with introspection, because I think if you don't understand who we are and the diversity, equity, and inclusion as a workforce, as a staff, as employees of Blue Shield, we will not bring the right intention, will not bring the right, I think, assertiveness, attention, and openness and humility to this work. So we're beginning with ourselves, and how do we encourage diversity, equity, and inclusion within our workforce? And second is we have to be about action. We're a health plan. The health plan takes in resources or takes in money to provide benefits, which provide access to care and other services. That has to be about improving health equity. It's not just about more members. It's not just about the average. It is actually, are we driving toward health equity? And then as a California nonprofit for the last 80 years, we believe we have to be about social justice to address, and I'll get to this slide in a second, we have to believe that we have to take positive stands on social justice issues. While we as a health plan, and you'll see, can affect certain aspects of what Director Lightbourn laid out and Ignatius laid out around access to care, we think around some social services and other supports, we have to be part of the deeper structural solutions to address those things that are holding back Californians to achieve our full potential and leading to disparities in health outcomes and our well-being ultimately. So those are our three pillars that we've adopted at Blue Shield. But first and fundamentally, we're making a statement that all of our friends and family, folks who have heard Blue Shield speak before, we talk about healthcare worthy of our family and friends, it's sustainably affordable. What we've added is an emphasis on all of our family and friends, and which is why I started with the workforce of Blue Shield, to make sure that A, we reflect the diversity of California. Second, that we're inclusive as a workforce to bring in new ideas among our own team, but from the outside, from our members, from providers, and from our communities, to make sure that we're actually solving their problems and not our perception of their problems. We also firmly declare that it's unacceptable to have the level and persistence of unjustifiable health outcomes and health inequities that result in disparities of outcomes. So we are putting a marker down that that's not an acceptable status quo, and that we need to be part of the solution to be better. As I mentioned, we start with getting rooted. This is not a technical problem. It is both a will and a skill issue. So we need to get rooted in the reality of and grounded in the realities of the issues, the depth of the issues, the complexities, so that we actually are solving the right problems and that we're contributing to solutions that actually will be durable and drive impact. Second, and this is an issue that is near and dear as a health services researcher to my heart, is getting data. We really struggle as a state to understand the racial and ethnic differences, but by a number of dimensions, truly understanding the health and well-being, the access to care, all of these other issues for our populations and for our communities. And without that data, we won't know whether we're doing well, and we won't be able to target our interventions to make sure that they're reaching the target populations and achieving the desired outcomes. Third is then to drive and solicit impact, because I think as a health plan, sometimes you can become insular and think that we've got the right solutions and hi, we're the health plan and we're here to help. It's really important that you get feedback from community partners, whether it's community health centers, provider partners in the community, community-based organizations. Are we hitting the mark? Is it actually working? And then finally, is to tell our story. We do not intend to be a singular health plan. That's why we're so excited about CalAIM and the state's leadership on this, whether it's with the vaccine or with CalAIM and other initiatives undertaken by the Newsom administration. We believe this is an all play, and we believe that Blue Shield tells our story, both of our successes and our failures, so that we all can learn together and move forward. This is not about Blue Shield as the center. This is about Blue Shield contributing to a larger good. And the other thing that we deeply realize is this in partnership. We are a facilitator as a health plan. We facilitate payment. We facilitate access to care. We have to see our role as a partner, and the partnerships and the strength of our partnerships will be the strength of our success. And so what we're holding ourselves accountable, and we expect everyone on this call and in California, or whether it's our regulators, our competitors, our providers, or our members, is a healthcare system where everyone is treated, has fair and just opportunities to be as healthy as possible. So we take your view, Director Lightbourn, about it's not just access to care, it is ultimately getting to health and well-being, and that it has to be free from bias, racism, and discrimination. Those are real, felt every day, and we have to tackle those if we're really going to make progress. Next slide, please. And this just gives you a feel of where we draw the line as a health plan, or where we draw the line today. We have big ambitions, and we understand the historical context of health inequity is incredibly deep. From historical context, shows up and it manifests as social inequality or inequities. We know that policy decisions today and in the future, today and in the past have implications, and that they create structural and institutional inequalities that manifest themselves through living conditions, social factors, risk behaviors, health behaviors. Traditionally, the healthcare system has just dealt in the world of disease and inquiry and access to care and mortality and morbidity. We believe as well in a holistic health approach, and that's why at Blue Shield we've been piloting a number of approaches to increase access to social services, medically mediated social services, and things that actually address whether it's contributing to the governor's homelessness intervention task force and things like Blue Sky to address mental health conditions among youth. We believe that we have to move upstream as a health plan to truly live out our mission and improve the health of the population. Next slide. And I'll finish just with this is, in the business world or in business, you have to drive this work all the way through. We believe that health equity has to believe, next slide, we have a chance, that health equity is embedded in everything we do. So these are our strategies. There is no other strategy at Blue Shield. This is our strategy. And what I want to just share with you is that health equity is woven throughout as a demonstrable, tangible outcome that we expect to achieve. and a way that we work, and a way that we work and a way that we do business. So creating a personal high quality experience, that's where we live health equity, and we see it in our provider partnerships and for our members. When we serve more people, we want to make sure that reflects California and that everyone, regardless of race, ethnicity, or other characteristics, has access to the appropriate services that they need. And we know that inequity causes tremendous financial burden on our members and on the system. And so part of being a steward and financially responsible is that we begin to address those, both for Blue Shield members, but within the larger system together. And then just reinforcing a great place to do meaningful work. If our employees do not feel like we are a diverse and equitable and inclusive workplace, we will not be able to achieve our equity goals. And then finally, as I said, as a mission-driven nonprofit, we don't believe it's enough just to stay in our swim lane of driving health equity for the 4.5 million Blue Shield members. We believe it is part of our obligation to stand up for what's right and to advance, advocate, and support, both financially and through our voice, things that we believe will improve, will bring social justice to California and improve the equity, health, and well-being of our population. So we are fully committed to doing this and looking forward to partner with those on the panel and all of you on this call to make this vision a reality. Thanks very much.
Thank you, Peter. So we've heard a perspective from the state and then from a major health plan, a really important stakeholder. We're now going to turn to Andy Martinez-Patterson, who's the Vice President of Government Affairs for the California Primary Care Association, working with the community health centers throughout California who are so vital in providing healthcare to communities of color. Andy?
Great, thanks, Ignatius. And I'm so honored to be here with Director Lightbourn and Peter and my friend Tu at Asian Health Services. And really, I just want to reflect, I'm not originally from California. I always thought California was kind of like crazy with fires and falling into the ocean and everything looked like LA. I'm a Midwest woman. But coming to California, I just want to it's not like this in the rest of the country. And talking about equity is really hard and getting to equity is really hard, but we're all talking about it. And I just want to acknowledge and put a point in that we're all working towards the same solution. And that is a tremendous opportunity for all of us. And even when it's hard, I hope we just remember that point, because that's what matters the most, is we're all climbing the same mountain, heading to the same place. We just might have a little bit of a different path. Next slide, please. So just quickly, who the health centers are. So the numbers are tremendous, and they, for me, represent a huge opportunity, but they are also a huge sadness. Health centers serve 1 in 5 Californians, and primarily are people of color, and the bolus of them, 80–90% of them are under 200% of federal poverty. So I think it just demonstrates the disparities in our state. I'm so grateful, and I think we should all be so proud that there are so many community health centers across the state, over 1,400 sites. It's not even including the intermittent and a lot of the mobile sites, 7.4 million people. And in Medi-Cal, it's 1 in 3, almost 4 million people are served by community health centers in the Medi-Cal program. So we are focused intimately. We were started because of disparities in communities, started over on the East Coast. Not surprisingly, California now has very many of them. We have a huge population, and we are deeply committed to the equity conversation and how to do that. Next slide. I'm going to be a little bit more nitty-gritty on the how on the equity and how well-intentioned policies can have inequitable outcomes. So today, and apologies for the simplicity of this slide, but I hope it demonstrates the point. Today, we are fee for service. Yes, as Director Lightbourn noted, health centers have PPS, Prospective Payment System, which is the affirmation that healthcare is more than just a doctor's visit, an MD visit. It also requires transportation and language translation and access and culturally competent services and dietary counseling and all the other things that go into a visit. It's not just 15 minutes. And fortunately, there was a larger sense in Congress and now across the states that that's really important. So it's the PPS rate. It doesn't mean that we get more money for a doctor visit. It means that we're doing a whole bunch more wraparound services and supports for patients, for individuals and communities that really need it. but it's a fee-for-service payment. And fee-for-service incentivizes and rewards providers for people being sick. That was not the intended outcome of what fee-for-service was. It really was to build up a system, and PPS and fee-for-service have built up a very strong community health center system in California, and we should all be so fortunate for that. However, it's not driving the right incentives. It doesn't drive towards equity necessarily. So today, right, you enter at the bottom of that line, you end up at the top, but that's not really enough. What we're trying to get towards is something where you blow up the line, more towards patient experience, more towards how the patient, the individual, the consumer needs care, what they value. And so then it's easier for to achieve outcomes when the health center can look holistically at the patient in order for that patient to be healthy, rather than being rewarded with a payment for when they are sick. Next slide. So this is my fanciest slide. Peter, I was really appreciating how nice your slides looked. This is my fanciest slide. This is the star alignment slide. So we have, where are we at, 2021? 2011, 2012 is when health centers started an APM, an alternative payment methodology conversation with DHCS, a long time ago. We are talking to them again now, and COVID, right? There's always an opportunity in a crisis, and COVID presented an opportunity to us. We have been talking about APM for the last 9 years. I think probably many of you who have been in this world for a while know that we tried. Actually, Peter was on it. We were trying in a different iteration at Blue Shield Plan, or the foundation, and couldn't get it across the line. But COVID showed us, man, if we had just had an APM, and when I say APM, I mean capitated payment, where it's not focused on volume, it's more focused on quality and outcomes. And if we had had an APM pre-COVID, health centers would have been on much more stable footing financially when all the visits plummeted, right? Because in COVID, when everyone shelters in place and health centers are a fee-for-service volume model, a ton of revenue started exiting the door immediately. So we had to turn on a dime. And fortunately, and I will say this time and time and time and time again, I felt like it took 2 months, but it was really 3 days of working with DHCS to get telehealth implemented at health centers and to be paid at the PPS rate, and how fortunate we are to be in California where those relationships were there, the understanding was there, and we reacted. And then health centers did not have to lose so much revenue, and they didn't have to lay off staff. They didn't have to take down services. We were able to keep going. But that it showed us, do we have to end up in another pandemic to learn this lesson? And the other opportunity was we were able to learn delivery reform before a payment reform, which is really important when a system that is 7.4 million large, thousands and thousands of staff large, thousands of sites large, how to do something before totally shifting all the payment, which requires kind of a flipping inside out, which, as we know, takes a lot of work. The other piece that I want to acknowledge is that the California Healthcare Foundation was there and has been talking to us about this and believes in this as well. So it really was a star alignment. It was the state, it was the health centers, it was the health plans. We've been talking to the health plans about this for a while, and the foundations all realizing we had to get back at the table and we had to figure this out. Next slide. So it wasn't, I would love to tell you equity was the reason that we all showed up and said, let's do this together. And that's, again, it's the reason for the mountain, but we have different paths. However, there is deep alignment in many places here that have equity threaded through them. They're just not in the words. Behavioral health access and integration is very important for the state. It's been very important for health centers, and it's very important for the plans. We're all trying to achieve this, and we all see community health centers are a really great model for where we could see if this could work really well. We all want to improve quality. When you have a fee-for-service model that is driving volume, and then you have P4P and HEDIS measures that are not necessarily linked to volume, you have the wrong incentives, and so we're showing up with wrong HEDIS measures. Health centers, when you can align and allow the health center, the staff and the team creative flexibility about what that patient needs, you're gonna see, this is my theory, someone can call me on it in 10 years, but you're gonna see HEDIS measures improve. The other thing is we want to make care more flexible. We learned that through the pandemic that consumers really want this, everyone really wants more flexibility. And we all want to see what that can result in. And of course, there's other pieces here too, but I just want to reflect how the star alignment is really important and equity is embedded in all of this. Next slide. This slide is more of the social justice cause, but I want to acknowledge something that a colleague friend of mine, Christine Noguera, CEO of Community Medical Centers in the Valley, that when they started health centers in the 70s, it really was about access. There were no primary care providers in low income, underserved areas, serving farm workers, serving people of color. There just wasn't any access. And so it was about the doctor visit. It was making sure that everybody had a chance to be well. But it's different now. Healthcare is more complicated. Health centers have been able to respond and it's more complicated. We have integrated behavioral health now. We have oral health. We have optometric services. We have multiple chronic conditions, and so you need bigger care teams. We have patient-centered health home. We have a much more complicated healthcare infrastructure. So no longer can we just talk about a visit. It's now about equity and justice, and we know that. We talk about social, all the stats that have been relayed on this call today, we know them. 20% is healthcare. The rest is not. So we can't keep paying for healthcare the same way. We have to enable the healthcare system to be as creative as possible to achieve this, what feels sometimes impossible, but we can do it if we put in the right flexibilities about equity and justice. Next slide. So here, this is boring, but for those of you wonkies out there, this is a model that we were building on in 2011. What health centers have been trying to do is get the base payment, which is right now PPS. Really, we're fighting for a long time ago, if you remember, pre the 2703 SPA for the health home pilots, we're trying to get a health home payment in addition to, and then trying to add in pay for performance. And back in 2011, we did not have this consistently across the state. So we were kind of fighting for all of these things to come in. And our belief was, if you note this kind of complicated arrows, that if you add in those investments in the P for P, that will save you money. So you're reinvesting the savings back into primary care, if that makes sense. Next slide. So it's fascinating. 8 years later, we went from rather than going from the bottom up, which is what we were trying to last time, we're going from the top down. I don't think that there's a health center clinic in the state that doesn't have a P4P program, that doesn't have a stronger relationship with their managed care plans in Medi-Cal. Almost everybody is PCMH accredited in some capacity. Most are participating in whole person care, enhanced care management. I also want to acknowledge the alignment with the plans and the state on this. This is really important. And we also have the flexibility in the care, right? Telehealth. The only thing we don't have is the payment flexibility to really enable the different types of providers, the different types of thinking, the different types of touches, be they, as we're talking about telephonic, video visits, maybe group visits, home visits, all the different types of touches that a patient might need in order to be the healthiest person. That's the last piece. And that's why we're back at the table. Next slide. I think this is my last slide, and this is the last kind of wonky little slide here, but it's to show you how today's model on volume are these little itty bitty widgets, and fee-for-service is very prescriptive because it's payer oriented. What does the payer value? The payer wants to know that you had a visit. That feels like they got something for their dollar. In a consumer-driven, value-oriented model, there's a lot more flexibility, right? It's so much less about the widget and the turning. It's more about the patient not having to take the day off of work. I know we use that example a lot. As a mother, anyone who has ever had a baby, not having to go to the ER in the middle of the night, instead talking perhaps to a nurse and avoiding that ER visit, that the baby's okay, that's totally normal behavior, all those types of things. That's consumer-driven value. And that's what we're trying to get to and believe it can open up a door to equity. It's not the end goal. It is certainly not the end goal. It is the door to a new type of a conversation that we're looking to have. And I just want to say here publicly, I know there are a million thousand priorities in the world, and I am so grateful, Director Lightbourn, that your team is willing to sit down with us. And our goal, at least right now, everyone cross your fingers with us, that we're going to get something across the line in 2023 for health centers to start doing this, because if we are impactful, That's on the lives of 7.4 million people, 4 million in Medi-Cal. That's a really big deal. So it's going to be hard, but we have to do it. And we can't give up this, not that we gave up last time, but we really have to push through any challenges that we have because there's just too many lives on the line not to do it. Thank you.
Thank you so much, Andy. So our final speaker is Dr. Tu Quach, who's the Chief Deputy of Administration at Asian Health Services, one of the community health centers that are part of the California Primary Care Association. And Dr. Quach is going to share a little bit about how Asian Health Services has approached thinking about these issues of delivery reform and payment reform, especially in the time of the pandemic. Tu?
Great, thank you, Ignatius, and what an honor to be on this panel. I'm happy to share what we've been experiencing and what we've been doing to respond to COVID, but I want to highlight that we're just one of many health centers, and what do they say? If you meet one health center, you've met one health center. We're all so different, and we're all really there to serve our unique and our very diverse communities. Next slide. A little background on Asian Health Services. We were started in 1974 by students from Oakland, Chinatown, who knew and felt like their communities deserve quality health care. And the health center was started. We're a federally qualified health center. Our two pillars of work around service and around advocacy. And our work is providing medical, dental, and behavioral health to about 50,000 patients. And we proudly do so in English and in 14 Asian languages. That's just some of the languages that our community speak, and not all of them, but 14 Asian languages delivered by bilingual and bicultural staff. Next slide. I always love this picture. This is one of our famous general patient meeting that we would have every year or every other year prior to COVID. And it's when we bring about 500 of our diverse patients to a meeting to tell them what's going on. Here we're talking about, you know, the Affordable Care Act as it was being implemented. And you can see the patients in, I think it was 12 different languages with headsets, wearing headsets so that it's simultaneously interpreted. And it's not just sharing information to them, but hearing from them. So there was a famous story around 2000 when we were sharing about our direction, and one of our Korean patients went up and said, "How do you expect us to have good health if we don't even have good teeth?" And that led us to start our dental care services at Asian Health Services. So our patients really drive our direction and how we provide care in a way that responds to their different needs. And I love this quote from our CEO, Sherry Hirota, that says, "Our measure of success is not in how many patients we see, but also in how many are empowered to assert their right to healthcare." Next slide. So this leads us to COVID. You know, when COVID hit us, it was really a dual pandemic that our community faced, of fighting the virus, but also fighting the racism that our communities faced. It was sadly the perfect storm that came upon us. Right before that, February 24th, the public charge rule had just taken effect. It was causing chilling effects among immigrants, including our patients who are afraid to come in. And then you have the virus hitting us in March. And then the so-called terms around China virus really leading to all the anti-Asian attacks that were going on. We were seeing among our patients, our staff were being attacked right in front of our faces. And really, you talk about all the things our communities have to deal with, our health centers are dealing with that, trying to counsel patients, trying to deliver care. And at the same time, no one was coming to Chinatown and other communities, so restaurants were shutting down. Economic losses were being felt all around. And our communities essentially went underground, yet their suffering went in silence. It wasn't highlighted in any way, and it was, we saw it in our community of people just feeling like they didn't know how to come out. For our health center, we quickly switched to telehealth so that we can provide that care, continue care for them, and also keep our staff safe during the times of COVID. But it was a really hard time. Most of our patients are elderly. They don't know how to use telehealth. They can't get on the phone and see their doctor. And it was really, the digital divide in addition to all the language access issues that came into play. Next slide. I want to share a little bit of what our Asian American and Pacific Islander communities face, that the data was always working against us. Data is not disaggregated to highlight the hidden disparities. And even when we're constantly, the work of having to show the proof of disparity is always upon our community. So one example was around the death disparities for Asian Americans. And colleagues at UCSF published a study that said, hey, if you look at case fatality, looking at deaths over cases, you see that Asian Americans actually have the higher than what the general population is. And this was not just true in San Francisco and Santa Clara, where a lot of Asians are, and throughout California, but actually across the state. Across the nation in several states. And the data was showing this, but it wasn't being highlighted in the media. So the narrative was around this model minority myth that we're okay, despite the fact that we're constantly trying to show data that says otherwise. And this higher case fatality could have been because there was lower testing among our communities, because they were late in presenting the disease, or because there could be comorbidities that exist in our community. Another startling statistic is that we saw that for Filipino nurses who make up 4% of the national workforce, they made up a third of the deaths that were going on among nurses. And yet again, none of this was being told in the mainstream media as much as we would like to see. Next slide. So for Asian Health Services, we were watching all this and responding, and we decided to do our own survey with patients in our community. We got about 1,300 respondents. Most of them were our patients who were limited English proficient and a foreign-born status. Majority of them at the time that responded were Chinese speaking. Next slide. The results really highlighted what we knew. Only 3% were actually getting COVID testing. And when asked why they weren't coming in to get tested, they didn't know where to go. And so they were being left out because of language barriers, because of the digital divide. And yet so much around the COVID narrative was around how, the Asian American population didn't have high case rates. And yet we knew there was a problem around accessing the testing early on. And it was a disparity that we were constantly trying to say, hey, something is going on here. People aren't accessing, they don't know how to get there, and really, really advocating for our community. Next slide. So for us, we really reflected upon how do we respond to COVID and everything else and continuing the care that we were providing for our patients. It was really centered around cultural and linguistic competency and being a trusted provider for our community. So you really need the outreach that goes into the ethnic media that really has the language capability to get people out to get tested. And then also to get them to have the contact tracing that's needed to reach out to the cases and their contacts, and to be able to provide them with the case management support. All of that is about quality healthcare, right? And yet it was us trying to bang on the door to get that done. And now as we face vaccines, which we're just starting off, the same issues around language access, around cultural competency, and being a trusted provider to our community comes into play again and again. Next slide. We're fortunate to be working with our county who, really heard us through. And so in August of 2020, we were able to start up the first Asian American and Pacific Islander multilingual, multicultural COVID community testing site, where we were testing 300 to 400 people per day in different languages. We were in Oakland, Chinatown. We were asked to move to Fremont. We started up another site in the Fruitvale area. All of these were really important to meet the needs of our community. And then soon after, we actually started a multilingual contact tracing team. All of these are very critical in providing care to our community on top of what we were already doing in dental, in medical, and in behavioral health. Next slide. So now we're facing vaccines. A month in, we got the vaccines to vaccinate our staff, and then the next day to start vaccinating our patients. And I want to say, as someone who is working to get the clinic up and running and has been running for the past few weeks, it is not easy. It is not just about having the vaccines, even though that's a critical piece. It is making sure that they could access the appointments in language. It is making sure that once they get the appointment and they come in, that you have the intake information in the different languages so they know what's being asked of them. It is having the bilingual and bicultural staff who understand and can answer questions around why they need a second dose, the misinformation between Moderna and Pfizer and everything else that they're hearing. It is about explaining to them why they have to stay 15 minutes, why they need a second dose, and why it's really important that they get vaccinated but still mask. All of that requires a huge team, and all of in the time when we don't even know exactly how we're going to get paid for all of this. But we do it because it has to be done and because our communities need it. So I'm just stressing that point around the need for so much around language access. Next slide. I really applaud California for thinking about health equity. And it's interesting because there had been the health equity metrics that's really based around the California Healthy Places Index. And it's great because it has so many factors that we know affect health, and it's really important. I think this metric was really used around reopening for counties, but it could be used for other things like vaccine distribution and many more things to come. But what's missing in the picture for many of us who serve the community is factors that we know have been driving health for so long: language access, immigration density, cultural competency, a better measure of income to poverty ratio that highlights poverty in a much more instructive way, race and ethnicity, all of that to say, hey, we really need to look at not just say health equity, but really think through how we measure it and how we really pay for it. Next slide, and my last slide. For our communities, we say that our fight with COVID has been a challenge and goal of preventing being simultaneously blamed for the virus and being overlooked for COVID services. And it's something that we really want to highlight during this period. So I look forward to our discussion, and thank you.
Thank you. So let me go back to Director Lightbourn and pick up on Dr. Quach's last comment about the index. I think California, again, was a leader in the country in trying to think about equity in terms of reopening in the midst of the pandemic by using the Healthy Places Index. But as Dr. Quach noted, there are maybe some other factors that we should be considering. So Dr. Lightbourn, as you think about thinking of operationalizing equity by using these kinds of common measures and indexes and other data points, how could we as a state come together to get that kind of data and some agreement on considering these kinds of factors in making our decisions?
It's a good question, Ignatius. Let me address it in this fashion. One of the sort of goals of Governor Newsom's administration has been to try to say, how do we standardize across a wide section of state operation? What are the questions we're asking? What's the data we're looking for? What are the sources? How reliable? And what do we do with it? So whether it's the Strategic Growth Council, which looks at sort of economic planning for the state, or the Health and Human Services Agency, sort of in its broad sense, including public health, Department of Healthcare Services, social services, developmental services, Department of Rehabilitation, et cetera. What we're trying to do is sort of really get sort of agreed upon metrics that we are working from, both in terms of what we are benchmarking from, what are the extents of the disparities and inequities, and then what are the sorts of goals that we are specifically going to set, department, agency, sector of government, et cetera, to drive towards not just let's get things better, but rather what has to be accomplished by what date and in what fashion. And so that is definitely a sort of a work in progress. Just before this meeting, I was in a conversation with folk from NCQA, the accreditation group, talking about standardizing measurement factors to, sort of be applied with managed care plans in terms of disparity indexes, and sort of the importance of involving not just administrators or plans, but also communities, social service providers, et cetera, in how we articulate all that. So as Andy said when she was speaking, what is really important is that we are all having this conversation now, and sort of getting that standardized is going to be, and getting it institutionalized is going to be critical.
Thank you. So let me turn to Peter. So there's a question many folks know, but not everybody is aware that Blue Shield, the health plan, has been tapped to be what is called the third-party administrator to help the state distribute COVID vaccines. And there was a robust conversation yesterday afternoon about making sure that that role that Blue Shield now has includes equity and making sure that equity is considered. So Peter, do you want to talk a little bit about that rollout?
Sure. Thank you, Ignatius. And we're honored to be working with the state and partnering with the state around vaccine distribution as a third-party administrator, and know that the central issue, and I think you raised it at the conversation yesterday with Secretary Richardson, Secretary Galley, Surgeon General Burke-Harris, and Dr. Pan, is health equity, and that we have to, it's a mindset, and we have to think about this from the beginning, all the way throughout the process, from allocation to Dr. Quach, the issue of the Healthy Places Index and whether that's the appropriate measure. We have to think through how we're targeting allocation, payments, data collection, making sure they're actually collecting data at every aspect along the way. So there will be more announced, I think, next week is the plan from the state and from Blue Shield in terms of the details. But we are aligned. It was an incredibly important conversation, and I think to elucidate the level of effort and commitment that's needed to ensure an equitable distribution. So mass distribution and the tensions. The other thing I would say that was highlighted in the conversation is the tensions of speed and moving quickly, and standardization will generally drive you to a certain outcome. And then thinking about or working on how do you actually be intentional in terms of ensuring the equitable distribution of the vaccine. So more to come on this one. And I think we're incredibly grateful and informed by CPAN, CPCA, other stakeholders for laying out such clear guidelines, and frankly, lots of tremendous great work that's happening already across the state and has been happening over the past year.
So, Andy, I want to go back to something that you talked about in your remarks, which was this notion of integration. And at the state, we have what are called the whole person pilots, which are really trying to think about individuals, not just as patients with certain conditions or certain health needs, but really thinking about them as whole people. And so I think this idea of how do we really deliver, not just through payment, but through a system where providers are talking to each other, where care is coordinated. And as Tu mentioned, our oral health needs are being met in addition to our behavioral health needs and our physical health needs. So talk more about how community health centers could really be models for that in a way that a private physician, for example, accomplish.
Yeah. Well, once I learned about community health centers, and I didn't know about them until moving to California, I thought every human in the United States should go to a community health center. Who wouldn't want that? Who wouldn't want their dentist to be down the hall from their primary care doc and have access to the same EMR that their therapist has? That seems completely amazing and mind-blowing. And that they're rooted in the community, like very much like your neighborhood school. They're close to you, and it's people who look like you and are in your same community. It's a really beautiful concept in mind. And that is a huge opportunity for us in California. I think a rub has been, and why have we not used them more, is because they were created to serve low-income people. So then they were, deemed as clinics, and they were pre the community health center model. They were clinics, they were storefronts, they were on porches in low-income neighborhoods, in mobile vans at agricultural farms. So that's where they come from. I know that Kaiser has a story that they were maybe not the best health system back in the 70s, didn't have the best reputation, and now look at them, they are this tremendous model that is both plan and provider, and very much a wraparound service in many ways, like the health centers, but different. So I think the Cinderella story of the health centers can be very much like Kaiser. The rub that I want to note is the payment, right? Payment has been really, and I will say this again, you can't talk about equity and then not pay for it. You have to pay for equity. we have undermined equity at every pass, and we've tried to get at it. And I mentioned this last night, and you know, Godspeed. I use technology. I appreciate Silicon Valley, but there's something that you can never replicate in technology or in a private company that was for profit, that nonprofits just have a hold on, but you have to pay for it. They have locality, they have trust, and they have mission built into them. And that generates a huge following from the people that we're looking to engage. And you have to pay for that. It is not invaluable. I mean, it is in some ways invaluable, but it has a price tag on it. And it might feel like a lot, but ultimately, if we all talk about this the same way, if you invested in social determinants of care, you will save money down the line. That is the belief about the health center system. If you pay for it up front, you're not paying for it on the back end, and there will be enough in the system to do it if we're able to look that long term into it.
Great, thanks. So Tu, let me go back to you. And I love that example from the community patient meeting where, you know, the patient talked about the need for oral health services, and then your experience of really partnering with the community to find out what their needs around COVID have been that may have been ignored by the mainstream and by other systems. So talk more about this notion of really partnering with the community and empowering the community to speak in their own voice and to really have a say as we're having these conversations, big conversations about delivery and payment.
You know, thanks, Ignatius. I think the idea of investing our community shouldn't be an afterthought, and it feels that way through our payment system. It's like when COVID hit and we had to transform ourselves overnight to deliver telehealth and still bring people in to ensure that you can take care of the really sick individuals. And at the same time, you know, the payment wasn't there. It was so based on face-to-face, and we had to advocate and work all around that. But if we kind of thought of equity and looked forward and said, let's invest in our community health centers and in other places so that we're not just every time something hits, hurting our workforce. I mean, I have to tell you that during this COVID period, it was like we were asked to do 10 times more, and we weren't sure when the money was going to come. And it's happening that way even with the vaccines. We are putting every staff there to deliver the care, to be culturally and linguistically competent. And we're not sure. That's what our communities need. That's our mission. That's why we exist. But we're not sure how we're going to pay for it. And in a time when we're all hurting economically, some of our health centers can't even keep the full workforce. And yet that workforce is the backbone of all the care that we deliver, the bilingual, those hired from the communities, those that know it. And so when you talk about working with the community, it's investing in that workforce that can at a point be able to pick up the phone, which is what we did, call out and say, hey, don't come in. We need you to see your doctor. Do you know how to use a video? Do you know how to call in and actually get on the phone? And yet so much was asked of us. And yet the payment and the finances was really uncertain and still really is for us. And so I want to highlight that as we think about working with community, we need to continue to invest in the infrastructure so that every time we hit upon some crisis, some pandemic, or anything else that happens, we don't just chip away at our workforce and at our health centers.
Great. So in our final minute or two, I'm going to ask each of the panelists to give me one sentence of, especially given the CPEN participants in this conference, what's one thing a consumer advocate could do to really impact equity around delivery and payment reform? So what's an opportunity? What's something that they should be looking out for? What's something that they should be pushing for? So let me go backwards and actually go to Tu first. So what should a community advocate be doing or focusing on?
I think that there's racially biased data, and that we shouldn't rely on data alone, and we should really think about how data is collected and make sure it captures what it needs to capture.
Great. Andy? So let me skip Andy and go to Peter.
I think Ignatius, the most important thing is defining success. So defining success in a human term of what success looks like, because the system will just do what the system does. So defining success by what it looks like, for whom, by when. And I think once those parameters are set, then you have an opportunity to hold the system accountable and all of the actors.
Andy?
I dropped off for a second into
So what's one thing consumer advocates could do to push for equity? So what's the one question they should be asking? What's the one thing that they should be pushing for?
I think, to me, I would say keep the pressure on, and get to know a little bit more of the provider and the plan perspective. I will note that. I do think that getting a little bit more into the ops on why the plans do what they do, why the providers do what they do, will help make a little bit more nuance to the equity conversation. But consumer advocates can push more on consumer and patient equity than provider and plans can naturally do, because we have to make sure the system works at the same time. So that pressure campaign keeps us all on our toes, and we're here, and it keeps us all moving in the right direction.
Great. And Director Lightbourn, you get the last word.
Do not let this conversation be transitory. Do not let it be a fad. This has to be institutionalized at the core of everything, not just in areas of health equity, but in all areas of racial justice. This is 4 centuries after the crime.
Great, thank you. And I really appreciate the insights and perspectives that everybody shared. And for all those who were watching and listening. And so let me turn it back to either Carrie or Jeffrey for instructions and guidance for next steps.
Thanks, Ignatius. If you could advance the next slide. This was such a great conversation. I really appreciate everyone joining us. So we are at the close, sadly, of this conversation. Clearly, we need to have more of these, but in terms of next steps, I just wanted to highlight a couple things. Today is our big focus on data. We talked about, even our speakers today talked about data. Next up, we have data office hours from 12:30 to 1. Really hope that you will take a minute to join that session. You can ask your questions. You can bring your, bring all your questions, concerns there. A really great resource. Also hope you'll check out the virtual exhibit hall to connect with our sponsors. Please click Rate Session to complete a quick evaluation of this session. This will help us for future planning. We really appreciate the feedback. And come back tomorrow for day 3 of the CPEN Voices for Change conference. We hope that we'll be able to see you again to continue these important conversations. So that's it. And with that, we'll say thank you so much for joining us today, and we look forward to seeing you tomorrow. Take care.